So yeah, I mean, one more time, thank you, Sophie, and the CEO team for inviting me to be here today. And I'm delighted to have this 35 minutes, which is not too much, but let's make the maximum of it to share and reflect with you on how we can use intersectionality in geriatric oncology. And it means a lot to me to engage in this important conversation with you all. So let's see how it goes. So before we dive in, I would like to ask you to think about one thing that you would like to learn about intersectionality, anything that you really, or something that you are concerned. Yeah, something that brought you here today, if you can put on the chat. Sophie, you're monitoring the chat, right? Yes. Okay. Thank you. Yeah.
Yes. But for now, there is nothing. So once there is something.
Yeah. Okay. So, well, people, I mean, what I leave people just to write down, if you have anything to share, and let me move on, in the interest of time, and I will check it as we go along. So today, the idea is to, first of all, look at the context of geriatric oncology. Then we're going to reflect briefly about equity, equality, and health inequities. And then we're going to move into what is intersectionality, why this matters to geriatric oncology, what are the challenges and application, and the implication for research, policy, and practice. And then we will have some final thoughts. So to start with geriatric oncology, so we know that this is a discipline focused on the comprehensive care of older adults with cancer, and it considers both the physical and the psychological aging, the comorbidities, and the life expectancy. And importantly, it addresses ethical dilemmas related to treatment decision making in older adults with cancer. Now, in terms of the global picture, we know that approximately 50% of older adults are our cancer patients. We know that by 2040, it's expected that we will have about 20.7 million new cases and 12.7 million deaths among older adults. So this evidence shows us the public health challenge and why we need action. We need to understand how inequities emerge and how can we address them. So let's first reflect on equality, equity, and health justice. And this is important because despite progress, we know that many patients are not benefiting from prevention, early diagnosis, and cancer treatments. And to change the situation, I think we need to shift from thinking about equality, which means everyone benefits from the same services, and equity, which is about everyone gets the support they need, towards thinking about health justice. And this is about recognizing that barriers exist and proactively removing systemic barriers that cause cancer inequalities. And there is a global agenda to close the cancer care equity gap. But what are cancer inequalities or health inequalities in general? So when we talk about health inequalities or inequities, this is, we refer to the avoidable, unfair, and systematic differences in health outcome between different groups. Sorry, I moved this one. We know that about 80% of inequalities are driven by what is known as the social determinant of health. And this is about where we are born, live, grow, and work, and include the socioeconomic factors, the physical environment, and health behaviors. But it's also very important to remember that 20% of inequalities are generated within the healthcare system. And that is very, very important. So we need action both in this, to target the social determinants of health, but also the healthcare system. Now, many of you will be familiar with this model. This is the Dahlgren and Whitehead's model for the social determinant of health, or known as the rainbow diagram. This diagram has long helped public health professionals visualize and self-assess health inequalities, structuring the social determinant of health, moving from the biological factors to the broader socioeconomic, cultural, and environmental context. But the important thing is that while this model broadened horizon by encouraging consideration of the social determinant of health beyond healthcare services and the medical model, it has faced criticism for being too schematic and for not fully capturing the complex dynamic interaction between multiple axes of disadvantage. And this is where intersectionality becomes very important. So if you look at this diagram, which is now different, this is about thinking that to address health inequalities among all the adults with cancer, we must move beyond the hierarchical and somewhat linear thinking of the rainbow diagram. And we need to embrace multidimensional and intersectional approaches to allow a better understanding of how overlapping factors such as age and ethnicity, the socioeconomic position, disability, the health status, how all these factors compound and how these interact to shape cancer risk, cancer experience, and outcomes for all the patients. So keep this in mind, please. Why is also important that we look at intersectionality? Well, you may have seen that there's an increasing interest in using intersectionality to study health inequalities. There's a rise in calls for researchers to use this framework to advance the cancer equity agenda. Very importantly, funders are gradually incorporating consideration of intersectionality as a core requirement in grant applications. So you will have to demonstrate how you're going to use or address intersectionality. And in terms of policymakers and healthcare providers, there is this progressive expectation that they will have to lead intersectionality-informed policies and services. So let's go and reflect of what intersectionality really is. So first of all, I would like to show you this, this slide because many of you may know Kimberly Crenshaw, which is on the bottom left-hand side. Intersectionality, the term is coined to her work. However, I want to recognize other women that have been fighting for the rights of Black women and to advance the idea of intersectionality. So why intersectionality was coined to Kimberly Crenshaw is because she was working in the legal field, and then she used this example of Black women in the legal system to because she found that these women face discrimination not simple because they were Black or women, but because of both together. And the problem was that the legal system often ignored these compound experiences. So they only had laws for women and address sexism, and laws to address racism, but not that kind of a situation which was a unique position in society. So that's kind of like the idea. Now this has been moved forward to be used in health and to understand inequalities. And let me give you a very brief example. Let's say that we have this Black, disabled, older woman with cancer who wants to access cancer services. Now, if we think from the intersectional point of view, what we need to think is about there will be multiple factors that will influence her experience. For example, she may be worried that she will experience racism in the system when they go to the cancer services. There may not be diversity in the workforce. The services may not be tailored to her needs. The hospital may not be adapted for her wheelchair. She may speak a different language, and there may not be professional translators. She may come from a low financial background, not having money to, for example, to pay for transport. So as you can see, there are multiple factors that will compound to make a unique experience for her, right? So if we move then, if we think about why then intersectionality matters in geriatric oncology, it matters because older adults with cancer are extremely diverse group. They have a overlapping identities and different life circumstances. And we know many experience multiple barriers, medical, social, cultural, economic, and all these, like we're saying, they intersect and they combine in unique ways to influence that access to care and outcomes. And this intersectional lens, as I was saying before, will help us move beyond simple categories to understand the complexity around inequalities in cancer care. And this will make it possible to design research, policies, and clinical practice in a more effective and equitable way. Now, the challenge with in this intersectionality, and probably this is why we are here, is that there is no a blueprint. So we don't have a book that we can follow on how to use intersectionality. Among the challenges, I'm going to just flag some of them. I did a scoping review some time ago, and what I found is that there is inconsistent interpretation of intersectionality. And many studies they not clear, so authors, they don't clearly specify or ground their work in theoretical frameworks. Then the available data sets that we have to do research are often not designed to address intersectional questions. So people normally use secondary data and they don't explain why and how it fits the intersectional question. So normally this data set will lack diversity and the variables that we need to answer those questions. We also know that there are very few mixed methods studies, and this is very important in terms of intersectionality. There's another challenge, which is about most studies have been conducted in the United States, and this limits the global scope and the applicability of those studies. And if we think about this, we will probably agree that overcoming these challenges is essential to advance meaningful intersectional research. Now, there is another important challenge that I would like to highlight today. And this is about how do we measure intersectionality? And this is very challenging. I want to show this study from one of the seminal authors in intersectionality, and boldly says or explains that saying someone is black and lesbian and woman is not the same as understanding their experience as a black lesbian woman. So the challenge here is that the common way of measuring intersectionality adds up different identities independently. But if we do like independent adding up the different factors, the challenge here is that we miss the point about intersectionality, because what we need to think is about how we can show the various aspects of an identity. And very importantly, we need to show also how this interaction create a unique experience, say, by power and oppression. So the challenge is that intersectionality isn't designed for simple counting or testing linear hypotheses, and it's more about exploring how those overlapping social forces combine in unique ways, right? So imagine that thinking about how we're going to measure racism, and are we looking at a person who is black or Asian, or are we thinking about how I experience racism, or it's about the interpersonal racism? So this is all very challenging. But there are some solutions, and there are some hidden tips that we can use to understand and use intersectionality. And hopefully this is what we are going to take away today, that some indication of how we can do this. So the first thing I want to really make sure that you remember and you take away is thinking about this. Individual characteristics alone is not intersectionality. So thinking about being black and woman, only that is no intersectionality. And if there's no power, there's no intersectionality. So we're saying that if we're looking at the example we are continuing to repeat here, which is about, for example, a black lesbian woman, let's say, it's not the challenge about the point about being black or being lesbian. It's like being a black lesbian woman in the context that this person may experience racism and homophobia and sexism and all that. So please make sure that you remember this, or you can remember this figure, is that thinking about all these factors. How can you think about all the factors, the individual, the interpersonal and the system level, how they combine to make an experience different or an outcome different. The other point I would like to highlight today, and I think is very important, is when you use intersectionality, think about that ideally you need to use intersectionality from the very beginning of your study, or if you are designing a service, till the end. So from, if we talk about research, will be from design and up to the discussion, and making sure that you are linking all your narrative and the intersectionality runs and is linked in every section of your project. Now, I'm not going to go into detail, but because of the interest of time, but in our paper, we have created this list of questions that will help you think about the key point that you should incorporate in your research. So you can look at this on your own time. I wanted to highlight it here. That will be very helpful. There's like 30 something, whatever question that are very useful for for your research. But here is an example of a study that I did, a qualitative study. So I'm going to focus on the qualitative first. And I can show you here how this point about how to use intersectionality ran from the very beginning, from the title, then making the case on your introduction. So what were the multiple aspects of inequality it is, and the elements about power and oppression. Then in the methods, how this intersectionality guide the whole study, and then in a discussion, contextualizing any findings in that point about the power, oppression, discrimination, and so on and so forth. And in terms of the results, let me show you what is important in when we use intersectionality, and especially for qualitative. In this study, I was looking at how and why women from Black and Asian background with breast cancer had different experience with services in the UK. And through the lens of intersectionality, what happens is that you can deepen your understanding and you have more nuance, this nuanced understanding of their experiences. And you can see here the way the questions were framed based on what Bowlet explained us, allow me to elicit that information, for example, about all the different experience of racism or microaggression these women had in the system. How they constantly have this pressure of that they have to be a strong women, strong Black women. How many, on many occasions, the healthcare professionals silence them, and they don't feel the trust to express their concerns, and so on and so forth. So you see that multiple factors influences their experiences. When we put all this together based on the intersectionality framework, what we saw in this study is that women with breast cancer from the Black and Asian background here in the UK, they experience multiple elements of oppression and discrimination. So there are different layers in their breast cancer journeys, and individual, community, and the healthcare system that put them in a position that they are more likely to experience inequalities. And this is on top of managing heart disease. So it's kind of challenging, and it makes us think on how can we better support this group. Now there is another study here which was about the survivors, all the cancer survivors. And these authors, again, they found there was the three factors that compound to influence the experience of these patients. And this is what is called the triple jeopardy in intersectionality, meaning that there are three factors that runs all the time and combine. Like in this case, there was cancer stigma. So these patients were feeling stigmatized. Then because they were Black or Latin cancer survivors, they were also feeling like that they were treated differently. And then there was the other layer, which was about being immigrant, which was another pressure on them. Like, for example, they were talking here that they were told why they didn't go to their own country. So you can see it's not only living with your condition, but then you're treating differently because of these multiple factors that you carry with you. So in terms of the qualitative, also intersectional qualitative research, what I will say is that if you're going to do a study, this type of study, please remember Bolek's advice and think about how you word your questions in your topic guide, because depending on how you word your question, that will influence how participants will respond to them. It's very important that we also bring along our participants and the community members to co-design the topic guides. And this is to ensure that the questions and the language we use is culturally appropriate. And then again, thinking about how you're going to develop your sampling strategy, thinking about who your participants are and who are you leaving out and why. Think about what is the role of inequity and oppression in your study, and what is the experience of discrimination that it may play in their lives. And then there are different types of studies that you can make. There's nothing prescriptive, so you can use interviews, focus group, whatever you want to use, but these key concepts are very important. So now I'm going to move into the quantitative research, so intersectional quantitative research. And I want to highlight that one of the most popular frameworks is this one by McCall. And she thinks about that we can use quantitative data in different ways. And she thinks about anti-categorical, intercategorical, and intracategorical. So the difference is, like, for the anti-categorical is that she thinks that it's not helpful to put people into strict groups like men or women or Black or white, because life is too complicated. And for these fixed labels, because people identities and experiences change and mix in different ways. So that is a complexity on how will you design a study in that way. Then we have the intercategorical, and this, I think, is the most common one that people use, because this is about comparing inequalities across group. So let's say that you want to compare cancer treatment outcomes among older Black women, all the white women, and all the Latino women. So you see, you have like you compare different the outcomes between different groups. And then it's the intracategorical design, which is about comparing inequalities within a single social group. Like, let's say, for example, you take only older Black women, and then you examine the differences, for example, in outcomes within that specific group. So these are the different ways that you can design your study. Now, I wanted to show you two examples. So this is, let me have a look, because I'm mindful about time. So these are two studies where you will see that the authors in each of them, what they recognize is why it was important to look beyond race or ethnicity, and how combining, for example, ethnicity, race, and sexual orientation, then they realize that these groups experience exacerbated inequalities. I'm not going to go into the detail because now I'm mindful about time, but this is a way of how you can do this type of quantitative studies. The most important thing I want to focus on is that if you're going to design a quantitative study underpinned by intersectionality, is that you need to be mindful that you need to move from the linear to the multidimensional thinking. So remember this first slide at the very beginning where we're talking about the rainbow diagram against the more holistic model for intersectionality. You need to clearly specify the intersections of interest. So, because what you often see in studies out there is that, people say, for example, okay, let's do ethnicity and sexual orientation, and there is no rationale for that. For for any other study for inequalities, you may do that, but for intersectionality, you need to really explain why you are combining these two. What is the oppression, discrimination? Why is the rationale behind that? You need also to think about recognizing heterogeneity between and within groups. Like, for example, here in the UK, we have this long list of categories about ethnicity, right? But very often the data is reported using the 5 main groups, like let's say white, black, Asian, mixed, and other. But if you think about that, when we put everyone, for example, in the box of black, then we're missing the point that the groups are different, because you will have people from originally sort of Black African or Black Caribbean. If you think about the Asian, again, a huge group with a lot of differences. So you have the South Asian, you have the Chinese, you have the people from the Bangladeshi, the Pakistani. So this is always keeping in mind that with intersectionality, you need to really just go more in depth to understand the unique difference of the specific groups. Again, sampling is very important, and if you see that there's any underrepresentation, think about how you're going to oversample sampling your target groups to ensure that you have enough and rich data to analyze these intersections. And then there's another very important point in intersectionality that, again, sometimes is missed in quantitative analysis, and this is that we need to move beyond describing and quantifying inequalities to focus on identifying the causal pathway and finding solution, because that's the purpose of intersectionality, is to understand what are the mechanisms that are perpetuating inequalities for some specific groups. Now, very briefly, I want to touch on to the clinical trials, and I think that's very important in geriatric oncology. And we know there's like many different challenges around clinical trials and older adults and treatments, either because they don't participate in studies or we cannot treat older adults with cancer because we don't have enough information in terms of toxicity, and so on and so forth. So anyone in the room, if anyone is interested in clinical trials, if you think about or you use the intersectional perspective, this is about thinking about how you're going to design more inclusive trials. Like, for example, how can you remove the upper age limit to avoid excluding older adults with cancer? Or how can you target recruitment strategies to ensure that you have a sample with multiple dimensions of inequalities, like Black older women, older cancer patients from minority ethnic groups. How you will tailor your trial protocols so you can accommodate for the limitations or the challenges that older adults face, like cognitive impairment or multi-comorbidities, and so on and so forth. Think about how you're going to adapt communication materials and consent processes to accommodate for diverse cultural backgrounds, language. So are you going to translate those protocols? And then how you're going to remove barriers. So how you're going to facilitate that these people can attend your setting, can you pay for the transport, and so on and so forth. And finally, only this is only to show you that there is also a group of researchers in Canada, and this is very interesting, where they have developed this intersectionality-based policy analysis framework. So anyone interested in policy, this is very important because they have they have this framework with different questions that help us think whether our policies are missing groups. How, if we are unintentionally damaging or negatively impacting some groups with our policies. And this is a very brief example of palliative care policy in Canada, where they were looking at whether whether the policy cover how, especially older adults, whether they prefer or they could die at home versus formal institutions. And when they were looking at the policy following that framework, they, first of all, then they realized how different the patients were. But then they saw that there were many patients that were underrepresented in the policy. And importantly, they realized that the policy was produced from a Western way of looking at medicine. So they were missing all the important dimensions from spiritual needs of the minority groups that live in Canada. So this is only a brief example, again, how important it is to come with intersectional lens, to start looking at the nuances within our protocols, policies, guidance, to ensure that we don't broaden the equity care gap in cancer. So now alluding
Yeah,
to what
5 minutes.
yeah,
5 minutes.
yep, just finishing. So I was gonna say thank you, Sophie. So alluding to what Sophie said, I will say think about what intersecting factor do you see as most neglected in geriatric oncology research. With all what we have said, I will just encourage you to think about that. And if you want to put anything on the chat, please do it so I can see when as we move along. So I have touched in many different factors, but in your area, is anything that you feel is neglected there? So I was thinking on that, and then I have so many questions already that I'm just considering to research actually. And this is only like, this is like very high level, but this is to help you think, like, for example, if we think about the policy, what is the role of bias in policies and processes influencing inequalities in geriatric oncology? Or, for example, how do intersectional factors influence pattern of inequalities in screening uptake, treatment, adherence? What is the role of intersectionality in terms of stigma and discrimination for geriatric oncology? So many things that we can study. I'm sure that there's more that we can do in geriatric oncology from intersectional lens. So just to finish here, what I think there are three elements that we can summarize why intersectionality is important. We will have been talking about research. Why? Because enabled us to get this nuanced understanding of the multiple factors that influence inequalities for older adults with cancer. For the policy, like we are saying, it helps us to inform equitable health policies, addressing multifaceted barriers. And then in terms of the clinical practice, it will help clinicians and all healthcare professionals to think to encourage more culturally sensitive approach to the way they work, personalized care, and then thinking about how can we promote inclusion of underrepresented groups in clinical trials, and so on and so forth. So I'm going to finish with this question for you. And I want you to, when you go away today, think about what is the one of the concrete change that you will make in your work or research to better incorporate intersectionality and improve inclusion of older adults with cancer. So think about that when you go home. What is the one thing that you can do differently? And to finish, I want just to highlight these two quotes, which for me have been very important in my journey with intersectionality. And this is about Hankiewicz, where she says that without doubt, this framework, so intersectionality, complicates everything. So we can see it's not as straightforward, it's quite challenging. However, Bowley also points out that we don't need to wait for methodological challenges of intersectionality to be resolved. So we don't have to have like this magic bullet to use it. What we need is just to have this intersectional stance and start using it and trying to develop and getting better at that. And this is me, Sophie. So thank you. And if you have any question, I am happy to take them. It's right on time. I'm so happy for that.
Perfect. Thank you very much, Ma, for this very inspiring and wonderful talk as usual. So, do you want to stop sharing your slides so that we can see you and can see everyone? It's easier for me too. And is there any question in this audience for Mar? While we are waiting for more question, I'm seeing some comment in the chat, sorry. So from Yorita, this is really encouraging and very relevant talk. Thanks. Coming from a low and middle income country, I feel the disparities depending on socioeconomic and cultural has to be more inclusive. She's coming from India.
Mm-hmm. So coming from, it's very depending on socioeconomic and culture. Exactly. I mean, but that's the challenge here is that socioeconomic and culture, this is so vast, is huge, is huge. But what we need to think then is like how we can kind of focus our studies to start unpicking what exactly. So, for example, if you think about the UK, in my studies, one of the rationale to look at the Black and Asian is that we know historically this population have migrated to the UK after, well, they migrated in the 50s and they were then they settle more in the more deprived background. So when we think about socioeconomic, we need to think why are these people in that situation, in that status. So we have to go back to history. We need to broaden our vision to articulate to be able to explain why these groups are facing more inequality. So definitely yes, more socioeconomic and cultural. Yeah, we need to focus more on that. Yeah.
Janice has a question. Please, Janice.
Yes, Sophie and Ma, thanks very much. I was just thinking, one step at a time, while for clinical trial design, we might want to enhance or have no limits on the age. And I'm not about statistician, so just to think out of the box and think aloud, maybe Ma could inspire us. So in our future design, say for older adults with cancer, shall we sort of like, I'm not good at maths, but maybe instead of just for open accrual, maybe we should have a good proportion of accrual for, say, a particular races or ethnicity, educational background, even the carers, because for the carers who are more educated or more have more access to better older adults care, like in Asia or Chinese culture, some of the carers will think that we should save some money for other stuff, but not to put the older adults for treatment, and thinking that cancer is a disease to death sentence. While we know the tempo of disease for cancer is relatively slow, so while age should not deter intensive treatment. So do you think that so that at least for study design, we include each of the little bit of the intersectional factors, ethnicity, educational levels, economical status? Will that help with the overall outcome of these trials to be more inclusive?
I mean, I think it's not a point about whether you need to include more for example, more people from a specific ethnicity or the education. I mean, ethnicity, let alone that every country have a different definition of that. So this is a challenge in itself. See, because if I talk, I mean, I don't know where you're based, but if I talk from the UK, that will be different, for example, from Spain or from how they define population to the in the United States. So you see that's difficult. I think the main concept is it depends on what you want to research and depends on your research question, and also looking at who are you living. I mean, I think the key point here is to reverse the question, which is about who are you leaving out and what will be the impact when you're leaving some people out of your design. We know, for example, in clinical trials, the majority of a study, in history, let's say, has been done in white populations. So there's a problem, and younger populations. So we have a problem because now we have medicines that we don't know. We don't have the full information. For example, for other groups, we don't know the information. We don't know if we can use it in older adults. So here is the question: is that with all the innovation that we have, who is not, I mean, the question is like, you need to think who is not benefiting from our innovation. So then these people should be in your trials. And when you are designing a trial, who are you leaving out and why? And I think this is more important than thinking about who you're going to go in, because by default, we will say, okay, let's do like 3 groups. Let's do this like ethnicity or age or whatever. No, stop and think who I'm leaving out and what will be the impact of leaving this group out. That would be more important, I think.
Thank you.
Is there any other question? Sorry, my daughter is talking to me. Uh, any other questions? I would have one because words matter. And
Yes.
I was wondering, just very naively, if there is any differences between the word inequity and inequality.
Yes, there is like a kind of very nuance in that. So in terms of and we use it interchangeably. And I know within the presentation I may have done that. We more often people will use inequalities to say the systematic, unavoidable differences into groups. When we put the inequity, is when the intention is that we include more like this unfair and unjust. And that is the main difference. So, and that's how we think about that. So in intersectionality, we will more often, or we should more incline to use inequity, because we need to think about these elements of justice, and fairness, basically. So inequalities is normally used as systematic differences between groups, and they can be avoided, where inequities include the concept of fairness and justice.
Yeah, and because in geriatric oncology, there are a lot of differences between, in terms of outcome, access to treatment, receipt of treatment, inclusion in trials, and so on. So do you think that it's a question of power, as you mentioned, because there is an intersectionality there, if there is power in play? So I don't know if in this case it's probably not only ageism. So do you think that those differences could be due partly to kind of a power in the same way that we can talk about power for racism or sexism, I'm not sure I'm clear because I'm not very into those concepts.
I think, okay, I mean, I think I know what you're asking for. So you're just trying to think like whether within the clinical trials, so we're talking about clinical trials, right? Or treatment
Not
in general.
only healthcare system and so on.
Or,
Just because in geriatric oncology, basically there is data. Basically, it's very no data for specifically for other adults. So clinician, there is no evidence base. So no special recommendation in the clinical guidelines. So it makes that clinicians are a bit, So yes, can we call that kind of it's power related or it's just another
yeah,
concept?
yeah. I mean, we of course we enter in a kind of a challenging territory here, but I will say there is power everywhere, because where there's someone making decisions, there is power there. Who finance different clinical trials, for example? Who set the agenda? Who is sitting at the big table making those decisions? So for the geriatric oncology, that's, I think, where, because I have been looking for studies in the whole, spectrum from policy, guidance, um, well, everywhere, and it's very little. So we cannot, no, but we cannot raise visibility of the challenges because there may be some agendas going on. So there's some interest there. And I think intersectionality can help unpick that. I know that our lovely colleague India and the team have done this beautiful scoping review about the guidance across Europe. And this is very, very interesting, and this is where it shows that intersectionality is so important in that one. How come in 2025 these groups are not represented in the guidance? So, and this is what we need to show. I think the point about intersectionality, Sophie, is that we have a tool to expose challenges and inequalities in a different way that haven't been done before. It's not about whether there is a higher mortality or not. It starts to unpicking and showing the decision makers, look, you are not including these people. And if you're not including these people, you need to say why. And this is all about ageism. And again, you have ageism, racism in older people. What about old people who have been, like from LGBTQ community, that now are leading with HIV and cancer and so on and so forth. So definitely, I think there is room. I mean, we cannot point to specifically who has the power and what exactly is, but I think we can do a lot of things through the lens of intersectionality to unpick and expose all this problem that you are mentioning.
Thank you very much.
Hopefully it's helpful. I don't know. Did I answer the question? Hopefully.
Yes, very well. Any other question? If you are too shy to speak out, you can write in the chat.
So is anyone doing intersectionality at the moment? Let's put on the chat. Are you working on intersectionality? Are you thinking to use intersectionality in your work?
Mm. I'm seeing a lot of people from the US, so because they are more in advance on that topic than Europe, but none. Oh.
Well,
Jennifer, no. Yes.
I was going to say, I mean, I think, yeah, this is not a primary focus of my work, but I think the current environment, of course, is making this more challenging to squarely kind of, use this kind of intersectionality lens in our research because of the administration's new priorities and lack of interest in certain topics like these. So I think that's not that it's definitely not stopping people from doing this research, but I think it is definitely discouraging, especially to a lot of young trainees who are probably trying to learn this and understand how to apply these methods in their work. So that's just high level from my perspective.
Yeah, Jennifer, I was going to say the same thing, Julie from the US, and a lot of work has been looked at of this, like it's been important for us to think about and consider, and there's been a lot of great trailblazing and new things. Our current administration is changing a little bit of the language that we use, and so we're sort of having to review language of how do you get the same message across without breaking any laws and rules? And so that is something that we're navigating right now of how to do that. And your work is really helpful and inspiring to know what's happening outside of our world. So thank you.
No, thank you very much. Actually, I mean, I was going to say, but you said, Judy, so thank you for that. I'm very aware, I mean, of the challenges that you are facing in that part of the world. But I also know from many colleagues that where there's a challenge, there is an opportunity. And as you said, is about rephrasing the way you articulate the message and you know how you do your grants. I know if you do no, you know, even intersectionality, if you mention EDI, so the EDI as well.
Yes, yes,
Yeah, again, you cannot use these things, but this there will still be inequalities and
right.
you know people going into A&E and you know
Yes,
and people just
yeah,
getting homeless and you know all these things and
yes,
cancer in our case, which is our topic of study, which is about oncology, is gonna the only thing that the only direction is gonna get worse because we have the
right,
aging population and so on and so
right.
forth, right? So it's how can we until hopefully, well, let me just rephrase what I said, until perhaps the situation changes over there, is how rephrase these approaches. And I'm thinking also that there's another point in my head for a long time now is about how can we do collaborations? Because when there are collaborations between the US and Europe, then it's slightly different. I know you still have you are constrained, but it's not unique to your country and whatever the
Right.
administration is saying. It's like, well, this is like data for everybody. I mean, it may
Yes.
be difficult to pull the data, but through collaboration, perhaps we can advance the agenda. So think about that as well.
Yeah, no, I love that. And I think that's where these meetings have been so helpful of looking how can we collaborate because the word DEI used to be so not used to is so powerful, but we are changing some of that and using words more of empowerment and identity. And I think those shared words are words that can cross our worlds. And it's the reality of where we are right now.
Yeah. Well, if I may, sorry, if I well have a one more minute, yeah, well, still, to say on that, I mean, you remind me now that I think it's also in the power of because it's power at the end of the day at all levels, right? And we also have the power, so the power also of the researchers and the communities how we move things forward. So, a few years ago, you know, kind of at the end of the pandemic in the UK, they changed the name of our health organization and they changed the word from inequalities to disparity. So now we have the Organization of Health Disparities, which we have never used in the UK. And for us has always been a word that is more used in the US. But these have a lot of connotations because the disparity have a definition. Like, for example, Sophie was asking about equity or inequalities or inequity or disparities, and these have a lot of connotation. And it's like, well, you want to change the word to soften what this means? We continue doing the research, and we're going to continue to expose what is happening, you know, to these communities. So there's always, I mean, it's not easy, of course, not, and we have to be mindful and all that. I think we can do things. So yeah, think about collaborations. That's I think could be one avenue.